My name is Alan Williams. I'm a trainee from London working in ICU in Sydney at the moment. Today I would like to talk to you about acute respiratory distress syndrome, looking particularly at the difficulties defining it and also potential therapeutic interventions. So the Ashburn 1967 definition was based on the 5 clinical entities shown here, and this was refined in 1994 by the AECC, who graded hypoxia by the PaO2-FiO2 ratio and also used pulmonary capillary occlusion pressures to rule out congestive heart failure. This definition was subsequently employed to enrol patients into clinical trials. Unfortunately, each area of the 1994 definition can be criticised and has led to diagnostic uncertainty in potentially up to 50% of patients. Importantly, it does not take into account how much positive end expiratory pressure a patient is on, and also radiographic and cardiac assessment has wide inter-observer variability. There are many predictive limitations to the definition. Is one PaO2-FiO2 variable enough, or would progression of indices be a better marker? We know outcomes are worse with certain inciting pathologies, and should time from insult and risk factors be included. This may all help clinicians when discussing prognosis and defining enrolment into clinical trials. So in 2011, the Berlin definition was drawn up to include PEEP to mitigate the inconsistencies that occur with ventilation. Time frame was added, and also the addition of the radiographic findings. Exclusion of cardiogenic failure was on the clinical impression of the treating intensivist with objective evaluations. The final Berlin definition has been thought to have a better predictive validity for mortality. So on the left here we have a normal alveolus. In ARDS there is diffuse alveolar and lung capillary damage secondary to the release of inflammatory mediators. The early phase is exudative with increased permeability of the alveolar capillary barrier as seen on the right. In the latter phases there is laying down of connective tissue, as you can see on the left. This is the proliferative phase with subsequent progression to advanced fibrosis. Resolution is variable once fibrosis has occurred. We often forget that ARDS can also affect the pulmonary circulation with pulmonary endothelial injury and associated microthrombi formation. This increase in dead space has been shown to be a powerful predictor of mortality. High transpulmonary gradient pressures were shown to be an independent predictor of poor outcomes in ARDS as well. So this slide just shows a typical chest radiograph on the right, and on the left just demonstrates the diverse pathological processes that can lead to one endpoint. Pulmonary sepsis has been shown to have the worst outcome, whereas trauma has the best. So inevitably patients progress to mechanical ventilation, but this can be harmful. Webb and Tierney showed that ventilation at low pressures did not cause significant injury in comparison to higher pressures, and the addition of PEEP was protective. Dreyfus used thoracoabdominal binders to show that high volumes, irrespective of pressure, produce severe lung injury and therefore volume trauma. The landmark ALTERNATE study in 2000 showed that protective ventilation strategy of 6 mL per kilo body weight reduced biochemical and radiographic evidence of ARDS and demonstrated a survival benefit. The provision of PEEP and preventing alveolar collapse was shown to provide protection from ventilator-induced lung injury, although high pressures could lead to over-distension of normal areas of lung and a slight increased risk of pneumothorax. Prone positioning has been shown to improve oxygenation in animal models via the following points, as demonstrated on the slide, but is rarely used in ICUs due to the mechanical difficulties of proning and also the risk of tube dislodgement and facial pressure sores. Inhaled vasodilators were postulated as a mechanism to reduce pulmonary hypertension and right ventricular dysfunction, but no studies have conferred any benefit using inhaled nitric oxide or prostacyclins, and they are usually reserved for cases of intractable hypoxemia. In limited trials, 48 hours of paralysis to facilitate ventilator synchrony has been shown to improve mortality, with no comparative increase in critical illness myopathy. Further studies are required in this area, though, to delineate the exact benefits. High-frequency oscillatory ventilation allows for a constant mean airway pressure with rapid pressure oscillations and reduced tidal swings. Carries a risk of barotrauma and also hemodynamic instability, but again has not demonstrated any advantages over conventional ventilation. ECMO is felt to be the gold standard for providing lung rest, but unfortunately can only be done in certain centres and carries its own risks. The CESAR trial in 2009 showed improved mortality in ECMO centres, but this was confounded by the specialist medical treatment delivered. Fluid therapy in ARDS is often liberal early on to treat a precipitating cause such as sepsis, but later on requires a more conservative approach to reduce the interstitial edema in the lungs. It's also been shown that a pulmonary artery catheter has no benefit over a CVP, and also the high PEEP and positive intrathoracic pressure can affect the right ventricular function and venous return and subsequent cardiac output. So despite the limited success of clinical intervention trials, it seems that prognosis is improving. But the question is that because the treatment of precipitating causes and the subsequent general care in ICUs has improved over this period of time? So, in summary, ARDS is caused by diverse etiologies that can lead to a common clinical and pathological syndrome. The definition has traditionally been inadequate, leading to difficulties in enrolling patients into clinical trials and difficulties with prognostication. Protective ventilation has been the only proven therapy to reduce mortality.